First of all, we've been listening to all the common macular pathologies, the common posterior segment pathologies for the last 1 hour. Now, my question is that what can we do in practice for them? The intravitreal injections, how can an anterior segment incorporate in his practice? We all are good cataract surgeons. We all have OCT. We all have a fundus photo. We need to understand the disease, the common ailments, why refer. The technique is simple, easy to master, good money and good results. So my talk will be in 4 parts. The first part will be the technique, then the type of injections, then when to give, and common protocols when to repeat. So you need to understand that just giving the injection is not good enough. You need to understand when you should give, how long you should give, and what all protocols you need to understand. So whenever we talk about the diseases, we talk about 3 diseases. First is the vascular disease, where the vascular permeability is an issue, like a central retinal vein occlusion, branch retinal vein occlusion, or a diabetic retina. Then we understand the choroidal diseases like IPCV or choroidal neovascular membrane. Dr. Tinku has very nicely shown how to differentiate between a vascular disease and a choroidal disease on OCT. And finally, the emergency situations like endophthalmitis. So we need to do a thorough pre-injection assessment, OCT, fundus photo, and decide whether we want a single patient vial or a multiple patient vial. I would recommend a single patient vial is more, it is much better because it is more safe. We are using it for one patient, so anything if happens wrong, will happen in one patient only. So this is a step-by-step, intravitreal injection technique. We open the pack. There's a thick needle that is there, because this is important, because we are going to take out 0.05 ml of the drug. So once you just clean up the center, this is how you take out the drug. You remove the air, then use a 30 gauge needle. This is from the outside. You have to very well understand that it is 3.5 mm from the limbus that you have to go. If the patient is phakic, then again you have to be more careful. If the patient is pseudophakic or aphakic, then 3.5 is, you are not going to harm the lens. This is how the thing is done. You have to give the injection right into the center, into the core. You don't even need to see the needle, the opening of the needle. So once this is done, this is how the surgeon sees through the microscope, 3.5 mm. Now you can see we are marking it with our caliper. We just, this is how the needle goes inside, and you can see the gush of fluid going inside. You have to put it only 0.05 ml, and then you can just close it. And this is again from the, now the site of injection is not important. Whatever is comfortable, wherever you feel that you can easily take the injection, because there are patients who are going to see on the upward direction. There are patients who see in the downward direction. Sometimes it is not very easy to do it in a particular quadrant. So whichever is more visible, you can do. So this is another video of Ozurdex injection. This is a steroid implant. Now this you need to be little more careful. You need to first mark, and then this is a thicker needle. You have to go in a slightly slanting direction and then directly into the vitreous cavity, and then just take a swab and finish it off. So this was one patient who was referred to me by an anterior segment surgeon who had actually injected a Ozurdex implant inside the lens rather than into the vitreous cavity. So we did the phacoemulsification. This was a diabetic chronic macular edema patient. And once we did it, we put the lens, and then I actually shoved the Ozurdex implant into the vitreous cavity, because I thought there's no point in removing it. It should work. The steroid that was given because of the chronic macular edema should work. So when we talk about injections, we are talking about, we need to understand that we have an anti-VEGFs, the regular ones, which can be an Avastin or Zydus. or a single dose ranibizumab injections like Eccentrics or Indian biosimilars like Razumab, Osiva, Macubrite. And then we have come up with new injections, which is like a VEGF trap or a decoy receptor like aflibercept, known as ILIA. And now newer anti-VEGFs have come like Pagenex, brolucizumab, faricizumab, and implant steroids. Now, as anterior segment surgeons, we need to understand what is the difference between them. If we look at these, the ranibizumab has been used for last few years, and you can use this Eccentrics injection, which is by Novartis, and it works very well. It is also not very heavy on the pocket, and in case you want a lesser problem on the pocket, then there is Indian biosimilars like Razumab, Osiva. Now these injections work very well for most of the indications, but if you can go in for a better anti-VEGFs, there is aflibercept, known as ILIA, and now newer things like Pagenex and faricizumab has come up. Now Pagenex is very excellent. It does an excellent drying of the fluid, but there is a small concern about vasculitis in 1 to 4% patients, so you need to be a little careful. Faricizumab is something which has come up very, for the last 2-3 months only, and this is also working well because it has a more efficient way of working. Another important aspect that I would like to tell you is that Eccentrics and all these injections, the company has come up with the various financial schemes to help the patients. So for faricizumab and ILIA, they have said that if you take one injection, the second injection will be free. So you can just take the procedure charges. So ultimately, if you look at the multiple dosing over a period of an year, most of these injections come out to be little similar. So that also you need to understand. Indications, as I've already said, these are the vascular causes, choroidal diseases, and the inflammatory causes. So we've already discussed them. For a CRVO with CME, as you can see in this picture, we have given an injection, and post-injection the fluid has decreased. So when we talk about the protocol or the algorithm, as an anterior segment surgeon, you need to understand how many of them you have to give. For a vascular occlusion, 1 to 3 doses of these injections at 1 month interval. Repeat OCT every month. If fluid comes back or is still there, repeat injection. If after 2 or 3 injections again the fluid is there, then you need to give a Ozurdex injection. So this protocol, if you remember, then you can easily treat your vascular occlusions. Then comes the diabetic macular edema. Dr. Tinku has very nicely explained you the nitty-gritties about diabetic macular edema. In short, if you have macular edema, diabetic macular edema, you can give all these injections. Normally, what is recommended is 1 monthly injection of ILIA or ranibizumab till drying occurs, and for maximum of 6 months, and then a maintenance dose every 8 to 12 weeks. This is the protocol that is usually followed across global protocol, but in India we usually take it for 3 months, and once it is chronic we can give Ozurdex injection, and we also need to understand that this can be exacerbated by cataract surgery, wherein Ozurdex helps us. Then comes choroidal neovascular membrane. If the choroid is involved, now you can see this patient in one eye, you can see there is a scar, the yellowish scar is there. The visual acuity in this patient is less than 6/60, while the other eye, the the CNVM has just started to develop. So this is the left eye, wherein you can see that there is a lot of fluid here, and we have been giving injections. What I want to tell you is that for any CNVM, if the patient says that, how long I have to give, you have to tell them that a CNVM will have a black shadow in front, and in case we give injections, that black shadow will go down and he will continue to see better. Once the vision goes beyond 660 and you can see scarring on the fundus photo and the OCT, then you can stop. So you can say that the natural history of the disease is what we are progressing. So if the patient, we do not give injections, then the patient will have this problem in 3 months. So if we give injections, he might continue to see for 3 years or 5 years or 10 years. I think my time is over, so I will not to finish the 3 loading doses at 1 monthly interval for choroidal neovascular membranes. Then treat and extend. As the name says, first treat, let the fluid go down, let the vision stabilize, and then just give one more so that it is extended. And then as and when required, we can also use Pregenex. So learn the indications, make algorithms disease specific, what to see, when to inject, and in which disease to treat. After a month follow-up, review the disease, re-inject if fluid decreases, but not completely. Thank you. I'm not going to talk about this endophthalmitis because for short of time. So intravitreal injections are like cataract surgeries. We all should know the technique, the indications, and obviously how to follow these patients. Thank you.
If you want, you can talk about, we have a bit of, I think that will be useful to the,
Okay.
yeah.
There's
If,
a
are you okay to,
uh,
I think you can cover it.
there's a small video for a minute. Uh, this is a any patient who has endophthalmitis and you want to give the injections. This is one thing which you can actually learn to master. Nowadays there is 23 gauge vitrectomies. Just give two two trocars and put a cannula from one side. You can see this. You have to see the center. Just go in. Now this is core vitrectomy. You just go in with a cutter. As an anterior segment surgeon, you can actually do it. Just see the opening of the cutter and just use it for 3 or 4 minutes. Just keep on doing it there. And then do an AC wash and an AC clearing. Take the sample. Once you've done this clearing, you can see I'm doing core vitrectomy for a few minutes. And then I'm giving my intravitreal injections. Now, since it's a valve cannula, so the injection will not come out. I usually give 3 injections. We can talk about it in some other forum. But yes, once these are given, you can remove the trocars. Now, the important thing that as anterior segment you need to understand is that we need to just debulk a small part of vitreous. Vitreous is almost 4 ml. If you talk about the volume of vitreous, we can remove 1 or 2 ml by just a core vitrectomy for 3 minutes and then give the right kind of antibiotic. If it works, then our endophthalmitis is going to be cured, and we can actually create wonders by just doing a small procedure. Thank you.
Thank you, Dr. Ashish, for that excellent update on intravitreal injections. I invite questions from the audience.
Sir, I have seen you giving the injections while betadine is still there, povidone is still there in that part. So usually we wash out that and directly give it. There is no problem, right?
No, I don't think so there's any problem, but usually what we do is that first we put a drop of povidone iodine and then we wash it and then we give it.
Oh, yeah. In all your videos, without washing, you just directly gave through that povidone iodine.
Yeah, it's better to wash it so that you prevent any inflammatory reactions. Okay. Point well taken.
My second question, you have given so many injections, so you are a master in that now. I want to know what are eccentrics and biosimilars. Have you got some difference in
No, I think it works excellent. Both the things work, but just the financial aspect. In fact, eccentrics has also come up with a wonderful scheme in which they say that give 2 injections and then third one will be free. So if the patient is ready for a multiple dose thing, then even eccentrics is financially similar to the biosimilars. Biosimilars are working wonderfully well. 0.05 ml. So it is not recommended because of 2 reasons. One is the IOP increases, and this is good enough for the disease that we use. 3.5 millimeter away from the limbus. Sir, for usually it is 3.5 ml for anything, but 3.5 ml for phakic is very important. For pseudophakic, you can even come to 3 ml. 3 mm.
Very nice talk, Dr. Lal. My question was for the whole house actually. Is there any tips or tricks for that stubborn, that hard exudate, which is not responding to anti-VEGFs or to steroids and is just sitting under the fovea? Contour is good, but vision is not coming back. What do you do?
So for such patients who have plaques of hard exudates at the macula, generally the dexamethasone implant works very well. You could also in conjunction start the patient on lipid lowering medicine.
Yes.
Statins, atorvastatin, or talk to the cardiologist. But sometimes in spite of everything, that hard exudate refuses to go and there's not much then you can actually do about it.
And a good systemic control also.
Yeah, there's one, it's just not going, so I thought that
I think just patience, you ask the patient to control systemic control, and then with time, sometimes it takes a pretty long time, But sometimes the hard exudates disappear, but they've left a lot of foveal thinning, then again the vision doesn't improve.
Some of them can't afford Ozurdex, so one is giving IV dexamethasone along with the
Yeah, though for those
anti-VEGFs,
plaques, dexamethasone works very well for those.
Okay.
Better.
So one can keep trying a couple of times, 3-4 times with the...
If there's no edema, then there's no point in trying. Just for the exudates, if there exudates along with edema, then.
No,
But if-
this person has only exudates. The contour has settled beautifully.
then then you don't
So
need
more
to
than one
inject.
steroid injection you want
No,
to try.
no, then you don't need to inject. Just keep the patient on lipid-lowering medication and follow up with time. Maybe they'll go.
Thanks, Alan.
Is there any point of giving intra IM or IV Dexona to a patient who has been operated and under the cover of steroids for uveitic cataract? Additional, just a stat,
IV or IM.
stat post surgery.
You can give intravitreal methylprednisolone, intravenous methylprednisolone, and that is better instead of just giving Decadron. It's very short acting. So, yeah. So I think
Already, it's patient is under control since 3 months and.
Yeah,
I generally don't prefer. I don't know about the literature on this.
Not for uveitis specifically, because for uveitis you need a longer control eventually. So probably if you have to give something IV, that will be methylprednisolone or something. But anyway, IV shot of steroid is recommended in case you have a prolonged or a lot of inflammation. Suppose you had a complicated surgery.
Yeah.
For that you can
Yeah,
give,
that-
not specifically for uveitis.
You could do that, yeah. I do that in a lot of my vitrectomy patients when I've had a longer surgery or I expect there'll be a lot of inflammation, then I do give IV dexamethasone. There's no harm in giving.
So this question is for the intravitreal injections. So what complications we should be looking for after giving the intravitreal injection? We should keep our eyes open for these.
Sir, first and foremost is the infection part. So you need to actually see the patient on the next day and maybe after a week and tell him that in case there is redness or irritation, then he should come up. Usually it is very, very rare. The second thing is that sometimes, you patch the eye and you can have a corneal abrasion and that can cause pain and, patient can call up. Then there is some redness for subconjunctival hemorrhage, which is not a complication at all. Otherwise, if you have done it right, usually you do not hurt the lens and everything is good. So you can always do a good examination after a month or so in your initial days. Otherwise, we actually do not look for the area where we are doing the injections. So
Yeah.
Any
One
danger
thing-
of
Yes.
Yes, that is one important.
intraocular pressure also is important.
One thing I
Usually
would-
with 0.05 ml, intraocular pressure does not rise. And for any glaucoma patients, you need to be little more careful.
any screening for detachment, retinal detachment required in these cases?
Post injection,
Yes, sir.
not exactly, sir.
Thank you.
So regarding the IOP rise, a good trick would be to ask the patient if he can see the light. Sometimes on table itself, the patient will not be able to see the light. That means your IOP has shot up a lot. And that is those cases you would need to do a paracentesis. Otherwise, generally it doesn't happen. But always ask the patient at the end, can you see the light or not?
Sir, with 30 gauge needle it is okay, but if sometimes with a 26 gauge needle you give that intravitreal injection, just after the injection some amount of thing comes out, is it vitreous or it is the injection?
No, it is mostly the vitreous. It's a vitreous wick that comes out. What you need to be careful is that you just, after you've given the injection, just try and, see it with your, with your swab stick, whether there's any vitreous or not. In case it is coming out, you just cut it with your scissors. This can usually happen, especially in Ozurdex implants, which is a thicker needle. So I would recommend only 30 gauge for the intravitreal injections, but in Ozurdex, you might have a small vitreous wick that can come out. Sir, it is always recommended to have a new needle because once you put it in the sclera, it becomes little blunt. So it is better to have a new needle. Even 26 gauge also can work, but you have to be careful. You cannot.
30 gauge is also fine,
30
sir.
gauge
30 gauge works for paracentesis. So, just the important tip I'll just highlight, while giving the intravitreal, always displace the conjunctiva like Dr. Ashish showed in his video. He was displacing the conjunctiva with the swab. And even when you're giving the intravitreal, instead of going just perpendicular, you can go a little tangential into the sclera and then turn your needle down. So that gives you a valved kind of an entry and makes it more safer. And then always use betadine at the end. Once you've given the injection, put a drop of betadine, wait for 30 seconds, wash it off. So that way you have a very safe procedure.
Even with 30 gauge, you have to go tangential slightly.
Yeah, it's better. It's better. It's not a must, but I think it's a better way to do it. It's more safer. It gives you a sealed, proper seal. Any of the panelists, anything to add?
Just want to add one more point. All these patients who have chronic multiple injections, AMD or diabetes, they eventually end up in a lot of dry eye symptoms because of probably repeated treatments, and also because they are on NSAID eye drops for a very long period. So yes, many of them, not in the initial phase, but after 6 months or 8 months, they start to get those dry eye symptoms and have to be put on lubricating eye drops for a long-term basis.
And most of them are on these NSAIDs like
Yes.
Nepafenac. They're on those. Once you start, the patient is putting them for years together. I've seen patients come back after 2-3 years
Still
putting the Nepafenac eye drops. So you have to tell them that you have to put them continuously. So if there are no more questions, we'll wind up this IC. Thank